I'm Dana Williams, and welcome to Afro Mosaic, the global Black lifespan journey. This is a year-long investigation tracing Black life from birth to over 100 years, through the systems that shape health, protection, opportunity, and survival. This is a 52-week, year-long investigation tracing Black life from birth to over 100 years, through the systems that shape health, safety, opportunity, and longevity. This journey examines how health outcomes are not random, and they are not simply the result of individual choices. They are shaped, quietly and consistently, by health systems, legal structures, social conditions, and economic design. This is Series 3 of Afro Mosaic, the global Black lifespan journey, and Ontario, Canada is our case study. But Ontario is not an exception. It is a window into a broader global pattern affecting Black communities across Canada, the Americas, the Caribbean, Europe, and beyond. This is not a story about personal failure. It is a story about system responsibility. This is about what health equity promises in Canada. Equity is a stated goal within our health system, but the question is whether those promises translate into real protection in people's lives. Before we continue, if you value work like this, visit amhg.ca. Please like, share, and subscribe now. Let's continue. Federal and provincial health frameworks recognize that not all communities experience the healthcare system in the same way. Ontario's health strategies openly acknowledge disparities linked to income, housing, geography, and access. Equity, in policy language, promises fairness. It promises prevention. It promises that where people live, work, and age should not determine how long or how well they live. On paper, these commitments appear strong. But equity on paper does not automatically become equity in practice, the gap between promise and reality. This is where the gap emerges. Across Ontario, equity is frequently articulated but not operationalized. Frameworks exist. Strategies exist. Yet outcomes for Black communities remain unequal and predictable. Chronic illness persists. Preventable harm continues. Life expectancy gaps remain. This is not a mystery. It is the result of systems that speak the language of equity without building the structures required to deliver it. When equity lacks enforcement, accountability, and sustained investment, it becomes rhetoric rather than protection. How anti-Black racism appears in healthcare. Anti-Black racism in healthcare does not always announce itself loudly. It appears structurally through barriers to access, through delayed diagnosis, through dismissal of symptoms, through undertreatment and fragmented care. These patterns are often mischaracterized as individual issues: missed appointments, non-compliance, lifestyle risk. But the drivers are systemic transportation gaps. Language barriers. Culturally unsafe care environments. Disconnected services that fail to see the whole person. These are not individual failures, they are design failures. Lifespan impact. The impact of these failures compounds across a lifetime. Early exposure to stress, instability, and exclusion becomes biologically embedded. Chronic stress becomes chronic illness. Preventable conditions emerge earlier and last longer. This is how systems shorten lives without ever naming race explicitly. When protection fails at one stage of life, risk accumulates at the next, and across generations, the pattern repeats. This is not a coincidence. It is a cumulative design. Ontario, as a national mirror, is often viewed as a leader in healthcare policy. That is precisely why it matters. Ontario reveals how a system can know what works and still fail to scale it. Integrated prevention-focused models already exist. Community-based approaches already show measurable impact, yet they remain the exception, not the norm. Ontario's challenges are not unique to the province. They reflect how Canadian healthcare is structured, who it centres, who it listens to, and who bears the risk when systems remain fragmented. What we see in Ontario echoes nationally. Protection and accountability. So what does protection actually mean? Protection means prevention, not crisis response. It means addressing root causes before illness takes hold. Protection means accountability at the system level, not asking individuals to navigate broken structures alone. Community-led models demonstrate what is possible when power is shifted, when trusted organizations are not consulted symbolically, but resourced and authorized meaningfully. Protection is not charity. Health equity cannot remain aspirational. It is designed. In closing, this is the work ahead. This presentation marks the third series in Afro Mosaic, the global Black lifespan journey. And across this series, we return to one clear truth. Health equity cannot remain aspirational. It must be built into systems, enforced through accountability, and measured by whether lives are genuinely protected. It must be structural. It must be measurable. And it must be enforced across the lifespan. From birth to elderhood, prevention and accountability must be built into the systems that shape daily life. Anything less leaves communities exposed to preventable harm. This work continues. Follow Afro Mosaic, the global Black lifespan journey, each week as we examine how systems either protect life or quietly fail it. Subscribe to Afro Mosaic Health Guide Magazine. Visit AMHG.ca to explore the series, research and tools. This is media designed to protect lives, not just describe disparities. Thank you for being part of this journey. Join us next week for Series 4 of Afro Mosaic, the global Black lifespan journey, which examines one of the most under-recognized protection failures in the Black lifespan, birth trauma and postpartum mental health. Using Bahia, Brazil, home to one of the largest Afro-descendant populations outside Africa, as a case study, this series investigates how obstetric violence, racialized medical practices, and gaps in postpartum mental health support shape outcomes for Black mothers and families. We center lived experience alongside system design, asking how care environments meant to protect life can instead inflict lasting psychological harm. This is the work ahead. Health equity cannot remain an aspiration. It must be built into systems, enforced through accountability, and measured by whether lives are truly protected. I'm Dana Williams, reporting for AMHG Magazine. Bye for now.